All right, well, thanks everybody for being here to hear me talk about perianal Crohn's disease and stem cell therapy. Not senior enough to have financial disclosures yet. Give it a few seconds here. I won't belabor the background too much. As we all know, we take care of a lot of perianal fistulas, most of which are not from Crohn's disease. However, if you do have Crohn's disease, then you have a lifetime risk of somewhere up to 28% chance of developing these conditions. And if you do develop these, it's usually very life-limiting for the patients. Up to 30 to 60% of them do not respond well to medical therapy. They typically have very poor quality of life. We're always taught to not operate on these patients unless they're very medically stable, which leads to the patients undergoing multiple drainage, CTOM procedures, and obviously it could lead to ostomy formations later in life. The need for something better to treat this is quite obvious. Stem cell management as part of regenerative medicine has been around for a while, and for fistula treatments, we're mainly talking about mesenchymal stromal cells, the MSCs. These cells are found, originally thought to be bone marrow derived, but really found in placenta, umbilical cord, and fat. The general mechanism of action is that we think this has a local downregulation of inflammation through a secretion of a wide variety of chemicals that selectively downregulate certain T cells and upregulate certain regulatory T cells, overall to create a more favorable wound healing environment for the fistula to close. These days, most of the stem cells we use are derived from adipose cells, the reason being that it's more widely available, easily accessible with very few complications. Your plastic surgery colleagues already harvest these, likely as part of their routine liposuction. And they can be obtained and processed with minimal work and be used at the index operation if needed. And using the patient's own stem cells, of course, bypasses a lot of regulatory barriers for using lab-grown stem cells. These adipose harvested stem cells tend to have good angiogenic properties as well as good proliferative properties. A little bit of history. The first report of stem cells being used for Crohn's fistulas was 2003. Since then, a multitude of smaller prospective randomized trials have been published. We don't have time to go over all of them, so I'll just pick out some of the larger ones. The FAT1 trial back in, I believe, 2012 recruited 200 patients looking at whether they had stem cells or stem cell plus fibrin glue or just fibrin glue. In general, they found no adverse side effects or significant adverse side effects, and a cure rate was about 40% across all arms. Of course, when they looked further into analysis, they realized that the primary center, when they were doing this, they had much higher rates of closure using the stem cells compared to the just fibrin glue itself. From this, the authors concluded that maybe at the satellite sites, they weren't so used to handling the stem cells, maybe affecting cellular degeneration. The more recent trials that we're used to hearing is the Admire trial, published long-term data in 2018. This is a European multi-center double-blind randomized control trial looking at an allogenic lab-grown cell line CX601 for the treatment of perianal Crohn's disease. About 200 patients were recruited, and at 1 year mark, they found healing at for about 56.3% of patients, with a control placebo arm having about 38.6%. The adverse events were generally about the same for both sides, with perianal abscess being the most common, and in general, severe adverse events were low, and they tend to be also related to the abscess formation themselves. I picked this recent meta-analysis just to give homage to the many studies that were done in the last 15 years, and in general, just to highlight that the stem cell group in general has maybe about a cure rate as quoted as high as 60% or so, whereas placebo arm tends to be about as high as in the 40% or so. In general, 30 million cells per milliliter is a favorable concentration, and for the most part, they've said adverse events for the stem cell group is low compared to the placebo arm. And there was really no difference noted between patients with IBD or without IBD for their treatment success. One of the bigger questions in this field of stem cell is, should we use allogenic or autologous cells? Allogenic cells are, of course, donated cells from healthy patients, and they can be expanded and grown in laboratories. The upside is that there's a lot of quality control on the concentration of cells. The downside is there's a very short shelf life, and there are regulatory barriers. For the most part, you can't get them in the US unless you're part of an FDA trial. For autologous cells, they're obtained from the patient and processed either with or without an expansion, which means they can be used at the index harvest operation. This bypasses a lot of regulational barriers, of course, but the downside is that there's variabilities in local technique and how they're harvested and in the cellular concentration. To date, there's no large head-to-head trial comparing which of this technique is better. Delivery method is another point of discussion. While most people in the studies favor direct injection to the fistula, many people have advocated for suspension of the cells in some medium, be it fibrin or plasma, and some people have used impregnated absorbable fistula plugs as a way of keeping the stem cells having a local effect. We'll talk a little bit about how we do this at UC San Diego. It usually begins with patient identification using some sort of imaging, typically MRI, to categorize the fistula, but also to make sure there's no large abscesses, typically greater than 2 centimeters or so. Intraoperatively, we tend to avoid local anesthetic use if possible due to in vitro studies of toxicity to the stem cells. Though if you have to use it, we recommend doing a pudendal nerve block or just keeping the local in the surrounding external skin. For skin prep, we use chlorhexidine, again, due to the cytotoxic effects of alcohol iodine peroxide. For us, we start with the plastic surgeons doing lipopreparation. They perform their liposuction, followed by centrifugal separation, or the Coleman method, mainly used because it's higher cellular yield as a result. Telfa smearing method is also feasible. It kind of depends on your plastic surgeon area of expertise. There are other methods of isolating. Our local plastic surgeons don't prefer them due to the concerns of cellular injury. And in general, the process is done intraoperatively in about 20 to 30 minutes. It starts with harvesting about 50 milliliters of liposuction, preparing it via the centrifugal technique, and handing it off to the colorectal surgeons for infusion. During this time, we prepare the fistula, and this is done with the ways that we're used to doing, which is identifying the tract with probes. We don't use peroxide, we use water, again, for the cytotoxic effects. We debride very aggressively down to healthy bleeding tissue. I cannot emphasize this enough. And finally, we make a very generous external opening to facilitate drainage. For the internal orifices, we close it primarily in full thickness using 2 or 3-0 monofilament. And finally, after this, we apply the stem cells themselves. It's usually delivered in a large bore needle or a Coleman catheter, injecting about up to 6 milliliters around the internal orifice itself. The rest is injected in 2 milliliter aliquots around the entire fistula's tract, avoiding not to inject too deep as to lose the local effect of the stem cells. Postoperatively, we have these patients go back doing their typical wound care, which involves sitz bath as needed. We give them about 7 days of oral antibiotics, and we follow up in about 2 or 3 months for symptoms. Since starting to do this in 2016, we've done this for 51 patients, and a lot of these patients actually get repeated injections of stem cell. So overall, we've done this 81 times, with a median follow-up time about a year or so. In general, the demographics is fairly diverse, and about 2/3 of these have Crohn's disease. A lot of the patients actually have had failed previous attempts, either via lift or advancement flap or some other form. Of the cases we perform, like I said, most of them are patients with IBD. Almost everyone is on biologic therapy. And while not everyone is on antibiotic or have identified proctitis, this is not an exclusion to getting the procedure. Most of the fats we harvested were from the abdomen. The results are, in general, at about 3 months or so, patients have an improved outcome for about 78%. This includes people who have had resolution or significant improvement in their life with decreased drainage, or a clinical evaluation of a much reduced size in internal orifice size, which helps to prepare you for an additional procedure in the future for possible closure. Of these patients, 52.9% have clinical fistula closure at follow-up. And of course, some of these people had multiple injections, so when we evaluate it as a case-per-case evaluation, the improvements are about the same. There's a slight decrease in the resolution per case of stem cell injected to about 44%. The complications are fairly low, with abscess formation being the most common, which were managed with local drainage. One came back to the emergency room for bleeding, did not need transfusions. And incontinence rates, a lot of these people had preoperative incontinence. Only one had worsening of incontinence, which was really attributable to progressive Crohn's disease. Just comparing outcome to conventional data, I think it's inarguable that there's a large variety of successes, not all of which are good for medical, surgical, or some combined management. But for stem cell therapy, again, with the data being limited, I think we can say with some confidence that the primary closure rate may be somewhere in the 40 to 60% range, with abscess being the most common side effect, and that's somewhere in maybe the 13 to 30% range. But of course, if the patient is next to a hospital, that's actually easily managed. Serious side effects tend to be very low. So in summary, are there shortcomings to stem cells? Of course. And that mainly is because it's a fairly new field with a heterogeneous genius approach. We can't really agree on the source, the dosage, and the harvest and delivery method right now. And it's undeniable that there's a strange placebo effect of some 30–40% of the people simply doing better with saline injection. But the pros, I argue, are, one, the side effect profile is fairly minimal. Yes, they have an abscess formation, but again, we're used to managing that if they're close to the hospital. And in most cases, we can say that the cure rate with stem cell injection is still higher, with 40–60% chance of resolution. And even if they don't resolve, they tend to have some sort of improvement of their symptoms, which may mean setting up for a more successful flap closure or additional closure in the future. And finally, the technique for doing this, your colleagues in plastic surgery are already doing it. It's not something you're having to do from the ground up. Get them involved, and I think they'll be very happy to participate. Thank you.